and good morning. And we are now going to take you through how we approach hepatitis B and what some of the preliminary data for efforts to really try and improve the hepatitis B surface antigen clearance rates. What we're going to call, as you'll see, a functional cure. The progress here has not been as rapid as it has been for hepatitis C, but as you'll see, we're just starting to get signals now that we will be able to hopefully make significant inroads for our patients with hepatitis B so that they can share some of the benefits that we've seen with hepatitis C. So the outline of the talk: global prevalence, the life cycle, and the utility of serologic markers, both current and what is coming. I'm going to try and explain just so as you see preliminary data, you'll at least have an idea of what some of these markers are that they're going to be discussing as we test a variety of novel therapies, current management of chronic hepatitis B, and as we gain a better understanding of our current treatment options, you'll see that really people are starting to become quite creative as to how we treat hepatitis B. And again, just a glimpse at some of the emerging options. It's early, but I think this glimpse tells us that we can be optimistic that there are going to be significant advances coming. So remember, hepatitis B is more prevalent worldwide than hepatitis C. In 2015, 257 million. Contrast that with about 70 million viremic individuals with hepatitis C. And North America, North America, South America, were relatively spared compared to other parts of the world, particularly the Western Pacific, Africa. They have enormous burdens of hepatitis B, vertical transmission in these areas. But because of immigration, all parts of the world have chronic hepatitis B, and it's an important disease that we have to be aware of. And as Ira very presciently noted, the hepatitis B life cycle is very complicated, and it probably is a major reason why we haven't seen the same cure advances that we've seen with chronic hepatitis C. But I would like to take you through some of this just because it will help you as we understand some of our therapies that we're going to be exploring. So here's our hepatitis B virion here, and it's you become infected, and this is a hepatocyte here. And so this is the sodium taurocholate polypeptide, co-transporting polypeptide here, which is how one of the major ways that the virus attaches itself. And then it enters the cytoplasm, and then the capsid, and it exists as just as capsid with enclosed DNA, which then goes to the nucleus and then crosses the nuclear membrane here and becomes this so-called relaxed circular DNA, which is converted covalently to CCC DNA, covalently circular closed DNA. And then what happens here in the nucleus is that the DNA is transcribed to a variety of RNA strands here, at least 4 of them, including this pregenomic RNA and a variety of other RNA transcripts here that then go into the cytoplasm, where they serve as the backbones to be translated into hepatitis B replication proteins, and there are a variety of these that then are assembled, and we encapsulate this pregenomic RNA here. And it is here then that we use reverse transcriptase to make additional virions, which are assembled via the endoplasmic reticulum. And remember here that some of the DNA here is recycled to the nucleus, and this is part of the reason that hepatitis B persists, is because you're constantly recycling as well as making new virions. So what are some of the serologic markers of hepatitis B? Most of you here, I know, work with hepatitis B patients, so you know these, but the hepatitis B surface antigen, which is a marker of infection or hepatitis B viremia here, and this is a marker of both acute and chronic infection. There are limitations to all these tests, but these are all rare occurrences except for the E antigen negative mutants. But again, if you have a cult hepatitis B where you have hepatitis B DNA without surface antigen, this will be negative. That is the hep C surface antigen, but this is a rare occurrence. E antigen means high infectivity. This is wild type hepatitis B. The majority of people that you're going to see in your practice are E antigen negative. just because over time they seroconvert. IgM core diagnoses acute hepatitis B infection as well as a hepatitis B flare. The surface antibody reflects immunity, and the core IgG is exposure to hepatitis B. And these are the serologies that you have to be comfortable with. There is now an additional test that was approved. It's been in Europe for several years, but is now available in the U.S., and that's just quantitative hepatitis B surface antigen. So just like we have a quantitative HCV RNA, quantitative HBV DNA, you can now measure the hepatitis B surface antigen level. And as it turns out, this is very helpful in distinguishing true inactive carriers, that is, those who do not have chronic hepatitis B infection, and it helps identify those individuals who potentially require therapy. There are data predominantly in Europe that show that you can quantitate the hepatitis B surface antigen during therapy, and those that fail to have a significant decline, you can use this as a marker of null response and a futility rule, and then stop a therapy as they're unlikely to clear. So some of us do order, we can get through this in the discussion, some of us do occasionally order this quantitative surface antigen. I found it quite helpful to use, particularly as we enter an era where we're going to have additional therapies. Now, what are you going to see as these clinical trials are reported out? Well, you're going to see changes in a couple of new serologic markers. One is the hepatitis B core-related antigen, and this is actually a variety of proteins. It comprises E antigen, the core antigen, and a core-related protein that are found in virion-like particles without HBV DNA. And these proteins here are products of the pre-core core gene, and they all share an identical sequence of amino acids. Probably most likely reflect cccDNA levels. Our understanding of how they respond to various treatment strategies is evolving, and so I would say for now, keep an eye on this, but there aren't standardizations. That's also true for hepatitis B RNA. So as I showed you in the life cycle, once the cccDNA is transcribed, you generate this pregenomic RNA. You can actually measure this, and this appears to be a marker of antiviral efficacy as well. It has the same current limitations, which is there are not standardized assays yet in existence, but it seems to correlate well with HBV DNA and cccDNA in some instances. In others, it doesn't correlate as well. And what I would say is within each study, we may be able to look at changes, but again, further standardization later is going to be very helpful. What about the current management of hepatitis B? So the natural history of hepatitis B has been classified in European guidelines, where I think we're the first group that actually made a very helpful distinction, which is they tried to define hepatitis B infected individuals as those with chronic hepatitis B infection, which means they have the virus but don't really have any inflammation in the liver. You have E antigen positive chronic hepatitis B infection as well as chronic hepatitis, the difference being that the ALT is elevated in chronic hepatitis. You have more significant liver disease, and it's when you have hepatitis that you need to consider treatment for hepatitis B. As you know, the natural history is such that you often clear E antigen, you become E antigen negative with or without therapy. And again, the same concept is that you can have E antigen negative infection, and this means a low level of HBV DNA. By the way, if you have an infection here, then you would also have here a low level of surface antigen, quantitative as well. But you also have flares of hepatitis, and there you have chronic hepatitis B E antigen negative chronic hepatitis B. So here the DNA levels are high, and here they're typically greater than 2,000, here greater than 20,000. The ALT is elevated, and you have liver disease, and the potential for disease progression is high. So in these two red boxes here are the groups that we generally treat for hepatitis B. And as I'm going to show you with all of the guidance documents, really all the guidances use this framework to decide who is an appropriate treatment candidate. And again, resolved hepatitis B means that you've cleared surface antigen. And again, this is our ultimate goal with or without therapy. So let's vote. What is the most important goal of hepatitis B therapy? We have ALT normalization, suppression of HBV DNA, clearance of hepatitis B surface antigen, prevention of hepatocellular carcinoma, or something else. So we have the majority of individuals, suppression of HBV DNA, and prevention of hepatocellular carcinoma. We can discuss this later on, but I think both worthwhile goals. In truth be told, all of these are actually goals of hepatitis B therapy. So here they are. You want your liver histology to improve. This means reduction in inflammation and fibrosis. You obviously want the HBV DNA levels to decline, and you want them to decline to undetected. You want ALT normalization. We've actually, now there's preliminary data showing that even with viral suppression, if your ALT doesn't normalize, your risk of hepatocellular cancer actually turns out to be elevated. And of course, seroconversion for those who are e-antigen positive is obviously a very helpful milestone as well. And so all are worthwhile goals of hepatitis B. So here are the recent guidance documents from Asia, Europe, and then two North American guidance documents, the U.S. treatment algorithm, and then the recent AASLD guidance document that discuss the management treatment thresholds for those with chronic hepatitis B without cirrhosis. And you can see they are largely similar. They differ slightly in viral level cutoff. So the Apostle and guideline, for instance, for e-antigen positive is 20,000, e-antigen negatives 2,000, the same as the AASLD guidance over here. Others are 2,000, and then they all have thresholds of ALT. And I show you the thresholds as they define. So Apostle was 40, EASL was 40, the US algorithm is 30 for males, 19 for females, the AASLD was 35 and 25. And the treatment thresholds, you can see, were either above the upper limit of normal or greater than 2 times the upper limit of normal. And again, when we get through our discussions, you will probably see there's considerable difference in these individuals with lower levels of virus as to who gets treated, but there are data to support all of these approaches, and we're going to go through some of this. The recent AASLD guidance had some very helpful recent updates also, which was that if you have somebody with an ALT above the upper limit of normal, but less than 2 times the upper limit of normal, that this requires consideration for liver disease severity by biopsy or non-invasive testing. And that if your ALT is greater than the upper limit of normal, again 35 for males, 25 for females, that you need to consider the age. A family history of hepatocellular carcinoma, particularly in a first-degree relative, I think would push most of us toward treatment, as would cirrhosis, previous treatment, and of course extrahepatic manifestations. If you have low-level viremia, less than 2,000 international units with cirrhosis, you need to be treated, regardless of ALT, to prevent flares, and decompensated individuals who are surface antigen positive, even with undetectable HBV DNA, need to be on antiviral therapy as well. In addition, an area that has been somewhat historically controversial is the immune-tolerant individuals, those older than the age of 40, that is normal ALT, HBV greater than 1 million international units. If you have a biopsy that shows significant inflammation or fibrosis, these individuals should also be treated, which means that in hepatitis B, unlike hepatitis C, we're probably going to be biopsying, you may be biopsying more individuals or non-invasively assessing their fibrosis as well with elastography or other methods. What are the preferred first-line monotherapies for chronic hepatitis B? Well, we have a class of nucleoside or nucleotide analogs, and we also have a cytokine, which is PEG interferon. And so our first-line therapies, entecavir, tenofovir, alafenamide, tenofovir, disoproxil, are all first-line therapies, as is interferon. And for decompensated cirrhosis, the dose for entecavir goes up to 1 milligram, and it's tenofovir. Notice tenofovir alafenamide isn't here, but it's imminent. It's going to be there. And so this is now our group of first-line therapies with decompensated liver disease. We don't use interferon, though we can use it cautiously in cirrhosis. So where do these drugs approved drugs work? So again, here's our hepatitis B life cycle. And as I said, nucleoside and nucleotide polymerase inhibitors, they inhibit reverse transcriptase. So they're going to be working here to prevent the conversion of RNA here to DNA, and you can suppress virus very potently, but as it turns out, actually, it's very interesting. With better assays and with more emerging data, even people who are thought to be well suppressed probably don't have complete suppression with just this very potent class of medicines. And in fact, at EASL, it was very interesting. There was a presentation showing that they could still infect hepatocytes in those who were suppressed on nucleotide therapy. So that just shows that despite this class being very potent, that we certainly have more room, and may explain why the surface antigen clearance rates in general are quite low. Interferon works here by stimulating your adaptive immunity. And again, as you all may be well aware of, that the hepatitis B virus is exceptionally good at suppressing the immune response, and interferon helps restore this partially, but again, it's not effective in all individuals, and it also has a year therapy with some side effects, but again, interferon works through immunomodulation, and it's this combination of therapies that we've had for the last 2 decades. I would like to put in just here a brief plug for an interactive tool that's out there to help you on the web, and this is a decision analysis tool, and you can go to the Clinical Care Options website under Hep B Consult if you have a patient, and it will help you depending on the part of the world you're in. It is stratified for the various guidance documents, and you can actually enter your data, and it will help you guide what the appropriate therapy and or follow-up or evaluation is. I would also like to say that it's available in all of the smartphone platforms as well. So make sure you have this available to you. Hepatitis B patients certainly can be quite complicated, and it's very helpful to be able to make sure that your treatment decisions are in line with the current management guidance documents. This was just a presentation at EASL showing that the newest nucleotide that was approved, tenofovir alafenamide, is really quite comparable to tenofovir disoproxil here. And you can see here this was a switch study, and you can see the virologic outcomes, TAF and TDF here, and the DNA suppression levels, they're identical. So the therapies really are identical. There was no virologic breakthroughs or resistance detected in either arm. And just remember that tenofovir alafenamide has a better renal safety profile and a better metabolic bone disease profile, but you aren't losing anything when you switch over from tenofovir alafenamide to tenofovir disoproxil, and indeed the ALT level may be slightly, as we all know, seems to go down with tenofovir alafenamide. What about for those with renal impairment? So I've listed here the dose adjustments that you need with both entecavir, tenofovir alafenamide, and tenofovir disoproxil. And just as a clinical pearl, what I would say here is that tenofovir alafenamide has is very helpful here because it's the same dose. And especially if you're a patient, I have seen this particularly, I think, in CAPD patients, those who get peritoneal dialysis. Sometimes it's very hard to get those individuals suppressed when you're giving entecavir or tenofovir at a dose of every 72 or 96 hours. And we seem to get better suppression with tenofovir alafenamide, and the approved dose here. It's just easier, in my opinion, also, as we've said, for a patient to remember to take a pill every 2 days, every 3 days, every 4 days is actually, I think, a bit challenging. So tenofovir alafenamide is 25 milligrams daily. I just think that's just easier to remember. So let's vote. How often do you use peg interferon to treat patients with chronic hepatitis B? So I think our people who are online and who are in the room, the cross-section is very similar probably to those that we have here. I don't know if the table at the front left actually voted, but I don't think it would have contributed much difference to this. And I think what we can see here is that interferon is not commonly used to treat those individuals with chronic hepatitis B. We always look for the ideal patients, but they're a bit difficult to find on it. So, how to monitor individuals who are receiving hepatitis B therapy. So, liver tests every 3 to 4 months in the first year, and then every 6 months thereafter. Check an HBV DNA level every 3 to 4 months in the first year, then every 6 to 12 months thereafter. You want to if you have a patient who has hepatitis B e antigen positivity, then you want to be assessing seroconversion after the first year to see if they have cleared E antigen and produced hepatitis B E antibody. The surface antigen every 12 months in those with undetectable HBV DNA. And if you do clear surface antigen, you should be tested for hepatitis B surface antibody. Periodic renal monitoring in those with tenofovir disoproxil and those who are at increased risk of renal disease that are treated with any of the nucleotide or nucleoside analogs. And finally, a serum creatinine every 3 months in the first year and every 6 months thereafter. When can we stop therapy? One of the most famous conundrums with hepatitis B therapy, particularly the oral therapies, are they're very easy to start, they're very hard to stop. So here, interferon is actually, here, if you will, has the most precise guidance because it's a finite duration of therapy. It's 48 weeks, and you then stop therapy and you assess your response. Again, you can't give PEG interferon in those with decompensated cirrhosis. For nucleotide analogs, it really depends on whether or not you have cirrhosis and your E antigen status. So if you have cirrhosis, it's indefinite. If it's E antigen positive, you consider discontinuation following seroconversion, and you typically consolidate for at least 12 months. And after 5 years, there seems to be about a 50% seroconversion. For E antigen negative, it is actually indefinite, though there are now preliminary data suggesting that selected individuals can have their nucleotide or nucleoside therapy discontinued here, and we're going to discuss this. But the surface antigen loss after 5 years of treatment is still disappointing at 5%, and again, we're exploring newer options. So here's a case of a 34-year-old immune-active hepatitis B antigen positive individual who received tenofovir for 2 years, seroconverted 6 months ago. That is, they cleared E antigen and produced E antibody, and she inquires about the possibility of declining or discontinuing the tenofovir. So she's again cleared, seroconverted for 6 months. So based on the AASLD guidance, she can stop treatment now, measure the quantitative surface antigen, stop treatment in 6 months if her serologies don't change, and must be treated indefinitely, or you just don't know. And very good. So 47%, that is our current guidance document. Now you can stop treatment within 6 months as long as she persists and doesn't keeps her E antigen away and produces her E antibody. Very good. So the AASLD guidance, again, stop treatment in 6 months if her serologies do not change. So you would consolidate for additional 6 months here, and there's no current recommendation for surface antigen cutoff, though this is an alternate approach. And this was reported by a large European consortium where E antigen negative individuals with surface antigen loss were followed. These were non-cirrhotic. And what you found was that the lower the surface antigen level, the more likely after you discontinued therapy, you were to move on to surface antigen loss. So again, this is surface antigen loss, and you can see here that if you, after discontinuing therapy, if your surface antigen is undetected or if it's very low, less than 10, you can see over the next 12 months, up to 28% of individuals lost hepatitis B, but if it was very high, the surface antigen level was higher, you didn't see this same clearance rate. So the level of surface antigen is probably going to have a role in this, but it remains to be defined. Just a brief word about pregnancy, hepatitis B treatment during pregnancy here. And again, when the viral level is high, greater than DNA level of 200,000 international units in the third trimester, that you need to initiate tenofovir disoproxil. And this is actually the preferred therapy. There is an alternate therapy, which is telbivudine or lamivudine, but you need to initiate therapy and discontinue their antiviral therapy at birth to 3 months postpartum. This was a very nice study by Calvin Pan done in China that showed that the per protocol analysis, that is, everyone who actually completed therapy, it prevented vertical transmission in everyone. Those that did not, who had the usual care, did have, there were 7 in the per protocol analysis, vertical transmissions. You can see here in the intention to treat it was higher, but these were lost to follow up. And again, breastfeeding is not contraindicated. Make sure you get your patients who are pregnant when their baby is delivered, get the Hep B immune globulin and the surface and the hepatitis B vaccination as soon after birth as is possible. And speaking of the vaccine, there was a vaccine approved in 2017, which is new. And so this is a recombinant single antigen formulation, and it has we hadn't had a new vaccine in 25 years. They're just 2 doses, and they be completed in 1 month rather than the 6 month. The other ones remain effective. And again, there's 2 single antigen formulations and 1 that is combined with hepatitis A, which makes it easier to vaccinate against this virus as well. Also, don't forget to screen your individuals who are undergoing immunosuppression. So if the surface antigen is positive and the core antibody is positive, anyone receiving immunosuppressive cytotoxic immunomodulatory therapy needs to receive prophylactic therapy. If your surface antigen is negative and your core is positive, then you need to monitor these individuals, or you can initiate therapy. If you choose to monitor, you must monitor. That means you need to check HBV levels, ALT levels approximately every 3 months and treat with any sign of reactivation. But in surface antigen core positive, without anti-CD20 therapy or stem cell transplant, the reactivation rates are quite low. And again, our preferred prophylaxis therapies are the same as our first-line nucleotide or nucleoside therapies. You continue these for 6 to 12 months. If you're receiving an anti-CD20 like rituximab, then you need to continue this for up to 12 months. So what are the barriers to cure? Again, high viral burden, a weak immune response, and as we treat these individuals, we're trying to clear surface antigen. So we start DNA decline with therapy, we make it undetectable, we clear surface antigen, and ideally you want to clear cccDNA, but surface antigen loss. So we're going to spend the last few minutes about emerging therapies and some of the preliminary data. So one of the exciting classes of therapies are the capsid assembly inhibitors, or core polymerase inhibitors, and they work, again, by preventing the assembly of the nucleic capsid here with a secondary mechanism over here as well. And by doing this, what they do is they actually either create aberrant core protein aggregates, showing here where you can't put the RNA in here, or empty capsids here that again interfere with hepatitis B replication. And so just a couple of weeks ago at the EASL meeting, one of the first core polymerase inhibitors, this ABI H0731, the preliminary data was shown in a virally suppressed as well as treatment naive populations. These were double-blind placebo-controlled trials, and the preliminary 6-month data was shown here. And when you add a core polymerase inhibitor to a nucleoside analog, what they have found at week 24 thus far is that you have higher rates of hepatitis B suppression. You had small signals. In the treatment suppressed groups that the e antigen level, it went down in 1, and the HBV RNA levels were lower here. And what this tells us is that you still need ongoing complete hepatitis B replication. But clearly the addition of a core polymerase inhibitor, as you can see here, shown here in blue, increases the viral suppression rates. It's still early for this class, and we will eagerly await the results of many of these core polymerase inhibitors that are in their phase 2 studies. In addition, we can interfere with the RNA as well, and this is a new technology called silencing RNA, where you interfere with the ability of this RNA to be translated by degrading it. And there are a variety of technologies that silence the RNA. These are called RNA interference. You have this major 3.5 kilobyte pregenomic RNA, and when you introduce these RNA interference molecules, you degrade the RNA and you prevent the future replication downstream of the hepatitis B virus. And again, at EASL 2 weeks ago, one of the first phase 2 studies was shown with this J&J 3989, which has RNA interference molecules that interfere with cccDNA integration-derived transcripts, this pregenomic RNA. And they had a variety of doses, either every 4 weeks or down to weekly. And these are all different cohorts here. You can see some nucleotide experienced, others treatment naive. And what you can see here in the surface antigen reduction levels are that with just 3 injections here, that you can see that surface antigen levels are falling. And weekly or every other week dosing levels also seem, when given in the first month here, all seem to reduce surface antigen levels. Again, it's early, but it's promising. We're starting to see signals. Remember that with our interferon and with our nucleoside, surface antigen levels fall very slowly. We're seeing fairly rapid declines fairly early. cccDNA degradation is going to be a strategy, and there are a variety of ways to silence this. I'm just going to show you a variety of therapies, and they're basically nuclease-based. There's this CRISPR technology. There are the zinc finger nucleases, as well as this TALEN nuclease as well. And all of these are currently being explored. None have really made it to phase 2 trials yet. But again, if you can degrade the cccDNA in the nucleus, then this will be a major advance in our treatment of hepatitis B. There are immune modulatory strategies also being pursued, and one interesting one is what we call a nucleic acid polymer. And these nucleic acid polymers seem to interfere with the assembly and release of subviral particles, and they seem to block hepatitis B surface antigen replenishment. And when added to PEG interferon and tenofovir, they lead to very impressive hepatitis B surface antigen clearance rates. And this was a pilot study that was shown where individuals with hepatitis B received tenofovir for 24 weeks, followed by this nucleic acid polymer with tenofovir and PEG interferon. And you can see the nucleic acid polymer was either added just after 24 weeks or after a period with interferon was introduced. And I'm just going to again show this is an ongoing trial, but look at surface antigen levels. And you can see here in green, when you add the nucleic acid polymer for the first cohort, the surface antigen levels come down very nicely. And that's shown also in the second arm, where they first received PEG interferon and tenofovir, and then the nucleic acid polymer. The surface antigen levels fall very nicely. They make surface antibody in a select group of individuals, and the DNA is suppressed. And there's going to be a multi-center trial. Dr. Peters, I think, will be part of this, where we look at where there's going to be a group of investigators that will explore this strategy. And again, we hope that we can see future promising results. Another immunomodulatory strategy is this so-called RIG1, which is a retinoic acid inducible protein. It's an agonist, and there was preliminary data with inarigavir shown here, which stimulates the immune system. And this investigational RIG1 agonist actually induces interferon production and suppresses viral replication by countering the interaction of the hepatitis B polymerase with the pregenomic RNA. And they received, individuals with hepatitis B received inarigavir at ascending doses compared to placebo. They all were switched to tenofovir. And you can see here, again, DNA levels with this immunomodulatory agent actually fell down from weeks 0 to 12 with ascending doses, both with the e antigen positive and then, not surprisingly, e antigen negative shown here. Obviously, with tenofovir added, they fell further. But this is another strategy which can increase the immunomodulatory effect. And again, to treat hepatitis B, we're going to have to combine these. Finally, one very novel mechanism is going to be to block the entry of hepatitis B. And one mechanism is with this bulevirtide shown here, which blocks the sodium taurocholate co-transporting polypeptide shown here and prevents hepatitis B from entering. This was studied in hepatitis B-D co-infection. And remember, hepatitis D is the most aggressive of the viral hepatitis entities that we have. And this study looked at PEG interferon as bulevirtide with interferon or as a monotherapy. And these were HDV RNA anti-D antigen positive individuals with hepatitis B-D co-infection. And what you can see here is by blocking entry, that you actually had significantly reduced levels of HDV RNA, and you had it with the 2 milligram dose here compared to PEG interferon. And you can see also here that ALT normalized, interestingly, very nicely with just the monotherapy without interferon, and that you also had surface antigen responses as well. So yet another mechanism and another strategy to try to treat the hepatitis B. There are a variety, and this is not a complete list, of other agents under phase 2. We tried to give you a broad range of the classes that are available. So the key take-home points are that when to start therapy really right now is an elevated HBV DNA in an e-antigen positive individual with 20,000 international units, e-antigen negative greater than 2,000 international units, plus an elevated ALT or significant disease on elastography or on liver biopsy. The thresholds for treating are starting to fall. Again, particularly in individuals with long-standing hepatitis B, high viral loads. Remember, hepatitis B causes the most liver cancer worldwide, and during the panel and question and answer, we can discuss how we all evolved to address these issues in our own practices. When to stop our current therapies, if you're e-antigen positive, it's seroconversion after a 12-month consolidation with negative HBV DNA. For e-antigen negative, you should assume it's long-term therapy, though again, preliminary data now suggests that there are select groups that you can stop these therapies in, although not all the therapy is consistent. We can talk about very promising data from Europe, but other centers, including the Toronto Center, reported results which weren't quite as promising, so this is an evolving area. Inadequate virologic response we almost don't see. Antiviral resistance we almost don't see. And again, there are novel agents entering clinical trials. Much like hepatitis C and other therapies, it's going to be combinations of mechanisms that lead to the best responses. My own belief is it's going to take a combination of potent direct-acting antiviral agents that will clear, and many of these individuals are going to need a degree of immunomodulation as well. It's early, but hopefully we'll be able to see some gains over the next several years. And thanks so much.